Now we're going to be looking at some of the more long-acting contraception options, and where we can talk about protection for years and not just a matter of months or days. And there's two methods we're going to be looking at. The first, I'm going to talk a little bit about the long-acting hormonal implant, and then we will look at the intrauterine contraceptive device. So starting off with the long-acting hormonal implant, and in our setting, it's mostly Implanon that we will be looking at. And this only came in the last few years and has proven to be, although a very useful form of contraception, is still quite difficult to actually get buy-in from our patients. It's safe, it's reversible, and it lasts for 3 to 5 years, depending on which particular preparation you are using. And it's easy. No frequent follow-up is needed. You can literally put it in and forget about it until they need to come for the replacement a few years later. So there's two options available in South Africa. The one we have in the public sector is the etonorgestrel single rod, which is the Implanon, or you also get a levonorgestrel, which is actually two little 75 microgram rods, and those can be implanted for 5 years. And they've got quite different techniques in terms of implantation. And the Implanon has got a very impressively low failure rate, and is actually one of our best contraceptive methods out there. So when you want to initiate it, you obviously have to exclude pregnancy first, and you can put it in any time. It's a little bit like all the other contraceptive methods, ideally within the first 7 days of the cycle if you want immediate protection. And pretty much, yes, the effect is achieved as soon as you've put it in. Because it's progesterone only, it also has that potential with breakthrough bleeding or irregular bleeding. But quite often, this can be quite effectively treated just with your normal NSAIDs, or if really problematic, you can even try tranexamic acid. There can obviously be a bit of pain at the site because you've made a small little surgical procedures. And then you just got to watch out if there are medicines that interact with progesterone, that's an issue. So we had a problem when the Implanon had been out for about a year, and then they suddenly realized that efavirenz could potentially reduce its effectivity, actually not that dramatically, but we suddenly had to give everybody warnings about potential pregnancy on Implanon, which was not ideal. Fortunately, we have now moved on to dolutegravir, so this is actually no longer an issue with our ARVs. Just to note, there might still be mythology out there about using the Implanon with ARVs, and these needs to be thoroughly squashed. And the contraindications is similar to our oral progesterone tablets. So the single rod insertion, and I've put in the, please check in our comment and the YouTube description, I have put some links to videos on actually the Implanon and how to put these in. They go subdermally just under the skin of the upper non-dominant arm. And the patient usually lies on their bed with their arm under their head. And the insertion site is about 8 to 10 centimeters from the medial epicondyle of that humerus, and 3 to 5 centimeters posterior of the sulcus. So look, if you look at that groove, that's between the biceps muscle and the triceps muscle. And then you go about 3 to 5 centimeters below that. So you want to get as far as possible away from that sulcus. And you mark the spot of insertion where you actually want to put it in. And then you're going to put 5 centimeter proximal. So you've got two little marks in terms of where it's going to go and in which direction. You clean and anesthetize, and then, as I say, it's got a little applicator, and please use the video to see how you use it. There's the names of the actual videos if you want to go and look them up, but I've also put the links in the comments. If you want to use the two little implants, also just look up the YouTube videos on that. This optimal insertion area is on the medial aspect also of the upper arm, about 6 to 8 centimeters above the fold of the elbow, but they inserted very differently. They've got a little disposable trocar like that, and you actually put them in like a little V in the shape of a narrow V. So a little bit more fiddly, but then you've got that 5 years of protection. When you want to remove them, that's also very important. So usually that'll be at the end of the 3 years, or with the two rods at the end of the 5 years. Usually you can feel them quite easily, but if for somebody's put up quite a bit of weight and you're struggling to find them, you might need to use ultrasound to guide that removal. Again, you mark the distal end with a marker, clean and anesthetize that area, and then just there where you've made your little mark, You make a 2 millimeter little incision with a scalpel towards the elbow, loosen any fibrous tissue and remove with a small, and then you can usually get quite often you can pop out, or you can remove it with a small forceps. And again, there's a little video in the comments to help. Make sure the removal is complete. So what you do is when you've actually taken your little rod out, you measure them. And the etonogestrel is 40 millimeters, and then the levonorgestrel 43 millimeters. So if we then look at the IUCD, very different type of contraceptive method, but also a very long-acting one. It's sometimes called IUD, the intrauterine device, but that abbreviation is a little bit problematic because it also stands for intrauterine death. So we like to use the abbreviation, the intrauterine contraceptive device. And it's suitable for most women. So what's great about this is because, especially the one of them are non-hormonal, you can actually give it to everybody, and even nulliparous women. So then there used to be a thing that no one can't use it on women who hasn't had children. That's not true. Very nice option for a woman who's not yet had babies. And also it works immediately, and we even use it as a post-exposure prophylaxis for somebody who wants who might have had unprotected sexual intercourse. So they last long, 5 to 10 years, depending on the preparation you're using, and that very low failure rate between 0.6 and 0.8%. The Mirena, which is the one that's got the progesterone on it, even lower, 0.2%. And these actually have a lower failure rate even than sterilization, and becomes a really, really good option. So very safe, very reversible. And what's amazing about this with both the Mirena as well as the copper IUCDs is that as soon as you remove them, you're immediately fertile. So that's why it's such a good option for somebody who might want to start a family in the next few years, and you don't want to have to wait for them to recover from hormonal contraception. There's no adherence issues. There's no frequent follow-up. You literally put it in and see them 5 or 10 years later. And you can put them in very nicely postpartum. Just note, if you are going to do that, you need to put it in within 48 hours after delivery or after a miscarriage. And if you haven't put it in, then there's like 4 weeks that you need to wait before you can try again. And it's also very nice and safe with breastfeeding. There's no thromboembolic risk, which is great. But obviously the issue with it is that it has this discomfort on insertion. And again, there's more of for the patient acceptability, it is more, a lot of people don't like the idea of it. And so usually the idea of it is usually much larger than the thing itself. It's literally not much more unpleasant than having a pap smear done. It's very quick, takes within 5 minutes that it's in. The actual insertion risk is extremely small. It's got a little bit of cost. But if you compare actually with daily contraception or any of the other contraceptive methods, it's still much, much cheaper. It obviously doesn't cause STI cover, just like most of our other methods. And the only thing is it obviously needs to be inserted by a professional or somebody that's got the tools and the equipment to be able to do that. Some of the contraindications, pregnancy, unless you want to use it to end a pregnancy. If you have vaginal bleeding, you can't just use the Mirena to sort out the bleeding if you don't actually know the cause. And obviously we can't use it with any endometrial or cervical cancers. Some of the more relative contraindications is if there's active PID or cervicitis or infection. And if they've got a history of 2 or more previous expulsions, some people's wombs just don't like them. Just very important. So somebody who has a lot of STIs, we're a little bit more nervous about using an IUCD, but one previous or the odd STI very occasionally is not a contraindication. So it's only if somebody is having regular issues with STIs that we might be more hesitant with an IUCD. And with fibromas or when you've got an abnormal type of uterine, also not ideal. So we have these 2 types. There's the copper copper IUCD. And some of the problems with the copper is if you've got very heavy bleeding, then it might make the bleeding even a little bit heavier, and definitely not want to use that in any of your cancers. For your levonorgestrel, so that's your Mirena IUCD, because that's obviously also releasing progesterone in the system. We also can't use it for somebody who's got acute venous thromboembolism, or you can use it for somebody who's had a past history of a DVT. Yeah, you can't use it if there's severe liver cirrhosis. Again, we've got to watch out if there's unexplained uterine bleeding, or if there's any cancers. So your options, your copper coil, there's one specific one that we have in the public sector, which is the T380A. It's suitable for patients on any other medications. And that's the 380 refers to the amount of copper that's on there, and we don't recommend using any of the other preparations that might have less. So the levonorgestrel, or the Mirena, that releases small amounts of levonorgestrel every day into the womb itself, and it actually causes this local atrophy of the endometrium. So it's got a very local effect. It's great for people who have menorrhagia or heavy bleeding, and quite often, most of the times, the periods will go away completely. So it will be your option of choice for somebody who actually wants to not have periods. And it can be used for, you can sometimes have migraines or severe headaches during use, but not nearly as much as, for example, being on the mini pill. So just to note that HIV is not a contraindication. It can be used in nulliparous women, and we should really think about it about our younger girls. And the only thing is that usually they recommend that in 4 to 6 weeks, you do a follow-up and you can put a quick ultrasound in the abdomen just to check that it's in the right place, or feel that the strings are there and all is fine. Some of the complications you just need to warn them about is sometimes people can have quite a bit of bleeding or extra bleeding, or pain with periods, for example. Some people might have a foul-smelling discharge, or fever on it, especially straight after insertion. And then, of course, some people do expel it and don't seem to tolerate it.